It's a great pleasure to invite Professor André Grotenhuis from Netherlands, working at the Radboud University. He's a well-known neurosurgeon and the program training director at the university as well. And I'm very eagerly waiting to see Andrew's presentation on the anatomy of the endonasal approach. The whole theme is endonasal endoscopic approaches, and it'll be good to see the anatomy and the nuances of the approaches as well. Thanks, André, for the talk. You can start now.
Yeah, well, thanks very much for the introduction, and Imad and Vladimir for the invitation. Actually, I think that for the younger ones, you already have seen the application of what I'm telling you. This is really now about anatomy. So I have no disclosures. I'm an emeritus. I'm not involved in anything anymore. So I will indeed review the anatomy, endoscopic anatomy, and then show you just a brief video of the surgical technique that will bring back all of these anatomical parts, and then have some conclusions. Just to remind you why we are switching, or have switched, from the microsurgical technique, at least that I learned in the 70s and 80s, to the endoscopic approach, because it brought in the light into the dark space of the nose. It has a panoramic view, so way larger, because there was no restrictive speculum. It was more easy to move your instruments, and it resulted also essentially in a reduced surgical trauma. But from the beginning, at least for my part, I always adapted a binostril endoscopic approach compared to the mononostril. That means that you only go through one nostril, but you still have to detach the septum and then do a bilateral sphenotomy, because otherwise you can't deal with the lesions. Essential is a lens scope with some irrigation. It will otherwise damp very easily, and the vision will be blurred. So if we look in a kind of practical way to the endoscopic anatomy, I always tell my residents that it is, you have the anterior part, which is from the frontal sinus to the posterior part of the ethmoid. Then you have the middle part, which is all about the sphenoid and sella itself. And you have a posterior part from the dorsum cellae down to the clivus. But due to the time, I will not address that one, because this would go into very, very more issues, and it would never be possible to cover that in 20 minutes. So the anterior part, the first part of the nose, let's look to the nasal cavity. When I learned transphenoidal approaches, it was getting that speculum as quickly into it, down to the area that we felt familiar with. That was the sella. The nose itself was not so well known, but we have to realize that the nose is the most superior part of our whole respiratory tract. It has a nasal skeleton, and it is has two functions, respiratory and olfactory. So the functions are so important. I can't discuss anatomy without telling about the functional anatomy of it. While we are sitting here and discussing and talking to, well, not to each other, only through the screen, we have to realize that it first, everything we inhale, it will be warmed and humidify. That's so important. And at the same time, the nose is able to remove and trap any kind of particles that we inspire. And of course, we also know that it is essential for the smell, a sensory function that is really essential for our human beings. And of course, it is the place where the sinuses will drain and clear the mucus. So if you look roughly to the nasal part, you see that the respiratory area is, of course, the largest. The vestibule, which is the entrance, is the smallest part. And the olfactory region, that's in the apex, that's in the higher regions. So the nose is actually more the area from the entrance, the vestibule, to the nasopharynx. That is the nose. That is the area we are now dealing with in endonasal endoscopic surgeries. If we look to the medial wall, then we have, you have to realize that the largest part is actually part of the ethmoid bone. The anterior part, as you can see here, is cartilage. That's the only cartilage we have. And the longer part, the longitudinal part, is the vomer that attaches to the palate. So if we look now to the lateral wall, so on both sides we have lateral walls, that is the middle wall with the septum. The lateral walls, we see these extensions, and these are the turbinates or conchae. And the two major parts of this, superior and middle, are part of the ethmoid bone, and the inferior turbinate is, and sometimes we say it's like the three fingers. So your inferior turbinate is like your middle finger, and the middle finger, the middle turbinate like your index finger. So this is the length of it is usually, at least by us as neurosurgeons, underestimated. Because of this subdivision, and that's very important, we have areas, it increases the area of the epithelium of the nose. And this is not only stratified and epithelium, but these have these so-called goblet cells that are secreting mucus. But because of these turbinates, we have areas where we have the flow. And the interesting part is that it is built that way that the laminar flow that comes into the nose is slowing down and becomes turbulent. So it stays much longer inside. So the area is increased, and therefore we have more possibility to remove particles and pathogens and also humidify and warm the air that we breathe. So they are very active organs, and we don't realize that. I think that hardly any one of you know that about every hour on one side, the turbinates start to swell, and we don't use it for air passage. It's only the other part. And then after 1 hour, the other part swells, and we use the other side. And that is, it's also resting. It's such an active and functional system. And I only tell you this to realize how important it is and how we can tamper with this important function when we start operating it. When I started in the early 90s, 1994, I did my first endoscopic pituitary with an ENT surgeon. And I thought we can just remove that all to get access. But he told me never to do that because it's so essential for the function of the nose. And of course, also the drainage. We don't see that a lot, and only if you do it yourself and go further and do ethmoidectomies, you learn the importance of the semilunar hiatus, where actually the frontal maxillary and the anterior ethmoidal sinuses drain. So always make sure, that was always at the end of the surgeries, I make sure that that is not blocked by any debris. I don't place anything because that will cause sinusitis. So the drainage, of course, from the sinuses through the nose is essential. Now to the vasculature. I mean, vascular supply and innervation. These are the things we have to learn when we deal with any kind of structures. You see that from the roof, we have the anterior and posterior ethmoidal arteries. This is not actually one of each. You have more of them. Some there are duplicated, triplicated, so there are more of them. They supply from above. Then the palatine arteries supply from below, at the same from the labial, from your lips. The labial arteries supply that. And altogether, these arteries, and the same you see here from the back, and we know that from the flap, everyone knows it from the Bassegetticui Haddad flap, that the sphenopalatine artery is important. These 5 arteries have anastomosis. They connect together. And ENT surgeons know this very well because nasal bleeds are more typically located at the area of this anastomosis, which is called the locus Kieselbachii, the Kieselbach area. And in the Anglo-Saxon area, it's also known as the area of Little, but it is the Kieselbach area that they have to coagulate if there is a nasal bleed. Just remember this. This is just plain anatomy, vascular supply. And now innervation. I mean, innervation are 2 parts. First, it is the sensory innervation of the area itself, like let's say the skin of your nose, that's trigeminal artery. You have the nasociliary nerve, then you have the nasopalatine nerve that comes from the maxillary nerve. But of course, the most important part of it is the whole olfactory innervation. You know that the bulb is it's part of the brain, and we always call it the first cranial nerve, but still it is actually brain, because the real nerves are these. These are the little nerves, the olfactory nerves, the nerves that come from the bulb and go through the lamina cribrosa. All these little tiny holes contain nerves, and you see that it is quite an area of the nose that is involved in olfaction. So tampering with this could affect that sensory function. And therefore, I wanted to show this picture. So when we use an endoscope and look into it, it's a typical going inside and then down, up. It's a kind of like diving into the water and coming up again. That's the way you do it. When we look initially into the nose, we see the inferior turbinate. We look for, when we pass it, we see the middle. We go below the middle turbinate, farther down until then we will see the choana. And from there, because the shaft of the endoscope is rounded, we can move up, we can dive up out of the water again, and then look upward, because the ostium of the sphenoid sinus is in the upper part of the sphenoid sinus. It's not low. The ostium is always there. There has never been a case of a non-ostium, that there was no ostium. The thing is that it is only in about 40% it is visible. In 60% it is covered with mucosa. But you have to know that it is there. So don't worry, you always find the ostium. And that is how it looks endoscopically. The inferior turbinate, if you look into the nose, that's the part you see first. Nasal septum here on the right side, so we are on the right nostril. If you pass the inferior turbinate, you see the middle turbinate, so between them and the septum, and in the depth you see the choana. So that is the initial way to go, the choana, and then you move in this way, the sphenoethmoidal recess and middle turbinate, if you move your endoscope up there, you see this sphenoid ostium. These are the only parts of anatomy that we need to know for a standard pituitary approach. So I'm not going for extended approaches. I will not tell you about the draft 1 and 2 and 3 approach to the frontal sinus and how to do extended approaches. That would be too far. But this is the typical pituitary approach. It's actually a very quick approach. It's very easy to follow that. So when you have done this, you will then enter the sphenoid sinus, and that's the middle part of the skull base of the area we want to go in. So if you look on the left side here, so middle turbinate again, of course this is enlarged, the ostium is enlarged. Actually, the ostium that you saw in the previous image is only very small, but it is in fact way larger. It's just moving the mucosa down, you have a longitudinal ostium. But if you enlarge this, you come into the sphenoid sinus. And that sphenoid sinus, you see the posterior wall and you have lateral walls. And typically what we see are all these different protuberances in the posterior wall. And the good thing is that they guide us to where we have to go. Because the sella, the sella floor is in the midline. How do we find it? Well, we have typically the protuberance of the optic nerve on both sides, then the bulge of the carotid artery, and we have the indentation of the clivus, and then we have this between the optic nerve and carotid. We have the medial optic carotid recess, and we have the lateral optical carotid recess. That's not always there, I have to tell you. It's not always there, but it is so important to see that because above the optic bulges, here we have the planum. And in between, a little bit more dark, is the tuberculum sellae, which is a thicker bone. So is the typical appearance of the sphenoid sinus. So it can be like here, you see on both sides, you see this recess, and a midline septum. I refer to that as the bulldog type of sphenoid sinus, where you have a clear indentation of the clivus. Here, the paraclival carotid arteries on both sides, and the carotid bulge, optic nerves. This is the easy way. Sometimes it's more shallow, but there is something else. And we call this the baby seal type of sphenoid sinus, a clear sella, and that is rather frequent. The bony septum is not in the midline, but is attaching to the carotid artery. So this is essential. The septae in the sphenoid sinus are not midline, they are multiple. They can be double, they can be triple, they can be vertical, they can be horizontal. And that's the thing that you have to study them. One of the reasons that we prefer to have nice CT scans, but it's not always possible to get it in all cases. If you have that, study that anatomy. A lot of these, like here, the septum is attaching to the carotid artery. You want to know that because if you enter here, you think this is the sphenoid sinus, but there is more to it. So then you would miss the midline. And the same here, you see an onodi cell in the upper part. If you would enter there, you have no clue where you are. But you have to realize that if you enter lower, this is not the whole sphenoid sinus. There is a horizontal septum still. So studying all these different, because there is no standard, but I have to tell you, these bony structures are your absolute anatomical guidance. If you know where they are, then it is easy to orient yourself when you are performing the surgery. We always say that in MRI scans, we can't see them. This is a macroadenoma. You see the pituitary gland on the left side. But then you have to play with the window on your screen, because then it is easy to see. Just on the MRI scan, they are all also there, but not on the standard setting. So play a little bit with the images. The same here. It's on the regular T1, it is difficult. If you enhance the whole Hounfield units, then you will see the septum, which is so important because you otherwise have no clue that you have to go through this septum before you are close to the sella.
1 more minute, Andre.
Yeah, I know, and that is, I finished with a short video of this to tell you how to perform this. Very quickly, I don't know. Well, in the Netherlands, we use cottonoid soaked in a solution with cocaine and epinephrine. If it is not possible for you to use that, you have the epinephrine, because this will reduce the swelling. So that's typically, this is already middle turbinate, inferior middle turbinate. These are the two structures you see first. You enter a nose. This is inferior turbinate, the larger one. And if you pass it, you see the middle turbinate. It's not complex. Inferior, middle, very easy. Go between those two. In the very depth, you already see the superior turbinate. Often we have variations, and the so-called spica, that means these lateral extensions, they are frequent, more often actually on the left side. I don't know why, but you usually can go above them, so you don't have to deal with them. And then we remember the ostium is in the lower part of the superior turbinate, the lower third. The superior turbinate is a little bit more whitish, that you can see here. It's whitish and smaller, thin. In that lower 1/3, you will always find the ostium. If it is not there, tap it with your suction tube, and you will fall more or less into the sphenoid sinus. You can use any instrument. You could use punches, this so-called the mushroom punch, or it was developed by Stamberger, who is an ENT surgeon from Graz in Austria. You can use a drill, you can use kerosene punches, but you have to enlarge it, and then you have to connect both of them. That already I told you all, so I will move this a little bit more quickly. You see this here. This is the sphenoid sinus with all the structures. So my recommendations is that you have to get used to endoscopes as often as possible. Get used to that instrument and the optics and how to handle it. And also make yourself familiar with this anatomy, because it is not difficult, to be honest. The individual anatomy, because every patient has a different nasal anatomy, especially in the sphenoid sinus, that's no trick. It's in the image. Study it. That's important. And I always tell you, because dealing with the nasal mucosa can cause bleeding, interact with your anesthesiologist. I tell them that the first part of the procedure could be painful on them, so they should give enough, and therefore we use the cocaine, because it is also local anesthetic. It's Moffitt's solution. And also the systolic blood pressure shouldn't be not too high. This makes your work as a neurosurgeon a little bit more easy. So in conclusion, I think that certainly I can say you have seen it in the previous few wonderful talks, how established this technique is already, not only for pituitaries, but also for other lesions like craniopharyngiomas. And we have now certainly equal, and I think in the hormonal secreting tumors, even better results than with the microscope. But I have to emphasize understanding of the anatomy is essential to do that. Maybe a nice job with the tumor, but if you tamper with the nasal functional anatomy, you decrease the quality of life of your patients, and you don't want to do that. So thank you all very much for your attention, and I'm looking forward to the next talks and next lectures, and if there are any questions, I'm happy to answer.
Thank you, Andre. Andre, that was a beautiful talk. You began by saying it's going to be useful for the juniors, but it is useful for everyone. I think learning about this anatomy can never be boring. And each time you hear the anatomy, it is more beneficial for each and every one of us. And I'm going to ask some of the panelists to ask some questions, but just one before that, one comment about, you mentioned about this cycle between the turbinate, they swell and then they go down after. It's quite interesting, because I think people who does breathing exercises in yoga, they often will realize that is,
Absolutely. The people doing that, they realize. We in normal life, we don't realize that very well.
No.
You only realize it during flights. And now we are not flying anymore. We are not. But then it dries out and you feel uncomfortable.
Yeah.
Because this tempers with the normal function and also the rhythm of when they turbinate swell, they recuperate. So then the mucus, the goblet cells do that. The turbinates are so-called cavernous structures. They can swell and they can decrease. They swell and decrease. I mean, if you had a common cold, not COVID, but a cold, then you also know that when it is swollen, it is on both sides, it's not comfortable. But it's about an hourly and sometimes by 2 hours, but it's a rhythm that we more or less only breathe through one nostril. We don't realize that.
Well, thank you. I think Ibrahim's Bey had got a question.
Thank you, Andre, for this very pleasant presentation. As everybody says, it's good for the juniors and for the seniors. A few of the endoscopists mentioned an observation. I'd like to see whether you have the same feeling. They say that whether you have one septum or multi-septi within the sphenoid sinus, one septum would always go to the carotid. Yes. Is that true? And yes. What was the incidence of carotid injury in your students?
Well, it's so odd, and personally, I never have seen experience a carotid injury. I always feared that I would. I mean, if you do 40 years of neurosurgery, you have to see a carotid injury. No, but to be honest, indeed, if you have one septum that typically curves and it goes into the attach on the carotid artery on one of the sides. I can tell you that sometimes there is not even bone on the carotid artery. I have seen 3 cases of that. And now I can tell you, because of the experience of one of my best friends, who told me that when it was a denuded carotid artery, and they removed all the bone and the keratin, and that lady, when she went home after 7 days, she experienced a carotid bleeding spontaneously at home and died there. What I always do when the carotid is denuded, also when I go into the cavernous sinus, I never expose that artery to the air. I don't know if that is true, but I always cover that with not only with fat, with gel foam, and with the flap or a part of the turbinate. I want that carotid artery really protected. But it's true. I tell my residents, never try to just break the septum away. In the sphenoid sinus, never break anything. Drill it, remove it slowly. Never take a rongeur and just break it off. Because I can show you the video where this happened, because Jeremy, a good friend of mine, showed me how this caused a carotid artery injury. So I have seen this, and I think I have been most probably the luckiest neurosurgeon in the world. With all my 1,700 pituitary surgeries, never had a carotid artery injury.
Thank you.
I'm just lucky.
Thanks, Andre. I think Igor, you wanted to ask something, Igor?
Yeah. Comment to the question at the same time. I would say some cases of tardive bleeding, such as you described, cases that were sent for us to the endovascular department for repair or occlusion. And discussing with our colleagues, the description was of no injury at all during the procedure. So I have some feelings, some thoughts about it. You know, the carotid artery there is not made to be exposed.
Yes.
Like you don't have the same, probably the same histology, the same adventitia, the same connective tissue around it as you would have, for example, in the neck. And then when you take everything that is around it, you take the bone out and you live like this, I'm not sure this will be at long term a good idea. And the question is, one of my thoughts is a possible mechanism of the tardive injury will be a thermic lesion due to the drill and you know, high speed rotation of the drill and the thermic lesion of the wall. Because the cases I was asked to treat, you know, some of them were, you know, the bleeding arrived several days after surgery. So what are your feelings about it?
It absolutely, I fully agree with you. That is an interesting thought, because with surgery, we change the natural habitat of the area. You could imagine, you could say, listen, if that carotid artery was never covered by bone, yeah, but it was covered with mucosa. It was with a very tiny little ostium and only had some airflow. We completely changed the whole structures there when we perform surgery. And indeed, the thermal injury is not neglectable. The thing is, I don't like the drills with attached rinsing, because this is much bigger and difficult to bring into the nose. So I have an assistant rinsing myself, but this is thermal. So if I drill the bone around that area, I can say that maybe this is a kind of adventitial damage that will cause a kind of pseudoaneurysm and then rupture later on. Because you are completely right. All those cases that I heard of and have seen, spoken of in the literature, they occurred immediately, but a few days later, or 2, 3, 4 days later. And for my friend, actually 7 days later. And that's odd. I can tell you that I have seen vascular catastrophes caused by myself quite a bit. And
Dr. Andre, I think about the catastrophe and complication,
we
will
leave
it
it on
for
Friday.
with Dr. Keki tomorrow.
Yes.
Okay, because I think we should be proceed. Thank you.
Thanks very much. So we'll